Any thoughts? One piece. Beautiful. You don't go straight to high power. For DF on your test, look at 2x, okay? Or whatever they have, 4x at the boards. Probably don't have 2x. The epidermis has hyperplasia, acanthosis, and flattening, blunting of the rete, okay? It's like an invisible force field that the DF is throwing up. The epidermis is trying to grow down to it and then hitting that force field somehow. At the edge, you'll see collagen that gets entrapped. The stain, again, is a little faded on this one, but normally you can see that big collagen bundles entrapped at the edge. Okay, there's your dermal collagen, and see how the little bright pink bundles of collagen are getting wrapped by the cells. Okay, that's helpful. Go around also and look for areas of hemorrhage. If you see areas of blood or hemosiderin deposition, strong point in favor of dermatofibroma. The last thing you should look at is the cytologic features. Do not go to high power. You're going to freak out. You can get big, ugly, scattered cells in dermatofibromas, totally benign. You can have mitoses in dermatofibroma, totally benign. You can have some fat entrapment at the bottom even, totally okay. Oh, look, see, there's some fat involvement there. So I get these sent to me when they entrap the fat, but that's okay. You do have to think about DFSP, okay, dermatofibrosarcoma protuberans, but most of the time you can tell DF and DFSP apart on H&E, not with immunostains. I do occasionally do immunostains to tell it apart, particularly if I have a partial biopsy and I can't see the bottom or the sides. So I lose a lot of those clues that I have about the interface with the collagen and the fat, okay? But fat entrapment is sometimes seen in DFs, particularly big cellular ones like this. This is a cellular DF. Giant cells, foamy histiocytes, Teuton cells, hemosiderin, blood, all favor dermatofibroma over DFSP, okay? Epidermal hyperplasia occasionally can be seen in DFSP, usually not, but I've seen a few cases that had real good epidermal hyperplasia and yet we're still DFSP. The other thing is if you see atypia, it's almost certainly not DFSP. Very, very rare to have pleomorphism in DFSP because DFSP is a translocation associated sarcoma, and translocation sarcomas have monotonous uniform cells. They all have the same DNA problem. They don't have pleomorphism. Pleomorphism is not a feature usually of translocation sarcomas. These do have some tendency to grow back, not necessarily because they're aggressive, but because they're usually superficially biopsied. So you're just taking the top of the iceberg and the rest is left down there and it just keeps growing, okay? Very, very rare cases have been reported to metastasize. Do not put that in your report, okay? Do you tell your patients that get basal cell, oh, well, this could metastasize? No, you don't do that because it's 1 in like 500,000 cases or less, right? Same thing here. I don't think Dr. Weiss, my mentor in soft tissue, said don't go telling people they're going to freak out and do big excisions, and the vast majority of them are benign, totally benign. I do tell people that if a lot of it's left in there, it could recur and they could decide if they want to either follow it or take it out. I personally think it's fine to just follow these. All right, cellular dermatofibroma. Also, these are known as benign fibrous histiocytoma. Cellular fibrous histiocytoma is the same thing as dermatofibroma. And they can even have necrosis. It's okay.